All right, good morning, everyone. I'm Ben Miller. I'm the Director of Pediatric Hospital Medicine here at UPMC Children's. And it's my pleasure and honor to introduce our Grand Round speaker this morning, Dr. Katie Forster. Dr. Forster is a pediatric hospitalist and researcher, board certified in both general pediatrics and pediatric hospital medicine. She earned her medical degree from Jefferson Medical College in Philadelphia, followed by internship and residency in general pediatrics at the Boston Combined Residency Program at Children's Hospital Boston and Boston Medical Center. After residency, she completed fellowships in both pediatric hospital medicine and general academic pediatrics at Cincinnati Children's Hospital Medical Center, during which time she also earned her Master of Science in Clinical and Translational Research from the University of Cincinnati. She then worked at Children's National Medical Center for 3 years before moving to Pittsburgh to join the Paul C. Gaffney Division of Pediatric Hospital Medicine in 2020. To date, Dr. Forster has authored or co-authored 65 publications, in addition to numerous published abstracts, oral presentations, and posters at national and international meetings. For the Society of Pediatric Research, she has served as the president of the junior section, as well as a member of the executive council. She spent 3 years as the abstract chair of the National PHM Conference, and she currently serves on the editorial board of Hospital Pediatrics and as the section editor on methodology. Finally, as a member of the Women in PHM Steering Committee, Dr. Forster won the National Pediatric Hospital Medicine Conference Collaborative Impact Award in 2022. As is pretty clear from this lengthy introduction, I am very proud of Dr. Forster's accomplishments and even prouder to have her as a colleague and friend. Please join me in welcoming Dr. Katie Forster.
Well, thank you for that very kind introduction. And I'm really excited to talk to you all today about my work in urinary tractions in children with neurogenic bladder. So the objectives of our talk today are to identify indications to obtain a urine culture in a person with neurogenic bladder, to develop awareness of the limitations of the routine urinalysis, or UA, for diagnosing UTIs in people with neurogenic bladder, to describe differences in the urobiome of people with neurogenic bladders, and to describe the effects of the antibiotics in the urobiome. And now I would love to come up here and tell you a nice linear tight story of, we identified a problem, we did some really cool methods and we figured it out. But I think like most things in science, it's a little bit like this. And unfortunately, we are about here. So we'll talk through the data that I have, and then maybe you can invite me back in about 10 years and we will continue the story. But it's a pretty complex problem and I've enjoyed wrapping my mind around it. A couple other caveats. I use the term neurogenic bladder in the introduction, although the more accepted term these days is neurogenic lower urinary tract dysfunction, or NLUTD, as it more appropriately encapsulates the entire spectrum of pathology that we can see in this patient population. Further, as we all know, people with NLUTD are pretty heterogeneous, and therefore it's difficult to generalize among this population. There are a variety of reasons a person might have NLUTD, but within this talk, we'll specifically refer to myelomeningocele when talking about pediatric patients and spinal cord injury when talking about adults and mouse studies. And because of the heterogeneity of the clinical population, the translations of the results to other etiologies of NLUTD just isn't clear. So when I say urinary tract infection, this is usually what people think about. You think about a variety of kind of irritated bladder symptoms. So maybe some hematuria, maybe some pelvic pain, urgency, frequency. And then in pediatrics, we diagnose this by the presence of urinary symptoms in a patient with a positive urine culture and signs of inflammation. This is pretty well documented within the 2011 AAP clinical practice guidelines for UTI. So within our general pediatrics population, although I think there is an argument for improving the way that we diagnose UTIs, in general, I don't think this is as large of a diagnostic dilemma as it is within the neurogenic bladder population. So you can have an asymptomatic patient with no symptoms. For some reason, you decided to get a UA and you don't see any signs of inflammation and the urine culture is negative. This patient clearly does not have a urinary tract infection. Comparatively, if you have a symptomatic patient who has either fever, is vomiting, has some urinary symptoms, they have a lot of pyuria, and they have culture grows out more than 100,000 CFU of E. coli, this patient has a urinary tract infection. And what makes this a little more clear cut is that the prevalence of asymptomatic bacteriuria, as shown by Dr. Shake in 2020, is pretty low in the general pediatrics population. So again, while I do think there is room to improve the diagnosis in otherwise healthy children, I don't think it's as big of a problem as it is in those with NLUTD. So what's the problem here? So all of a sudden, we have a different situation. The urothelium, so the lining of the bladder and the urinary tract of children with neurogenic bladder, they have a degree of chronic inflammation. This has been shown in studies of children and biopsy studies of adults, irregardless of the time or the etiology of injury. there is a degree of chronic inflammation, and this is necessarily going to confound your UA. Additionally, you have urothelial inflammation for those kids who need to catheterize. Regardless of the type of catheter they use, a low friction catheter, there's still going to be a small degree of inflammation, and this could also confound your urinalysis. There's this concept of neurogenic inflammation, which I don't think is terribly well characterized in the chronic state, but we know that it exists, and it probably also confounds your UA. These children are medically complex. They have a variable degree of sensation. They may be developmentally delayed and therefore not be able to express what they're feeling, and that also confounds our symptoms. There's this concept among clinicians that these children are chronically colonized, so they always have bacteria there, and that affects the way we interpret the urinary results. And then we also know that these children are at high risk of UTIs, so we have there's also clinician behavior anchoring, which is also coming into play here. And this is all complicated by the fact that the estimated prevalence of asymptomatic bacteria in this population is about 70%. So 70% of the time that you culture the urine from a child with neurogenic bladder, you are going to find bacteria. Which brings me to my question. How do you diagnose a UTI in a child with NLUTD? So my kind of first pass in thinking about this is, okay, let's use an unbiased approach. And so we decided to do urine RNA-seq, which I realize isn't usually most people's first step, but it seemed like a good idea. So I thought, okay, we're going to enroll 10 people at the point of care. And this is somewhat logistically challenging because urine's a finicky molecule. You have to process it a certain way within a certain amount of time. So I obtained some pilot funding from my prior institution, and we were able to obtain urine prior to the child receiving antibiotics within the emergency department, appropriately process and freeze it necessary to obtain sufficient urine RNA. And then I categorized them into no growth here. So those with negative urine cultures, we called the green or colonization. So kids that the clinician thought didn't have a UTI, but had positive growth in the urine culture. And then those that the clinician thought had a UTI and had a positive culture in the blue. And it looks a little something like this. So for those of you not familiar with looking at PCOA charts, what I would like is you're looking for clustering. So if these here were all like red, and these were all green, and these were all blue, I'd feel fairly confident that we had some signatures that were similar between these groups. But as it is, you can see there's really no pattern between what we see clustering on our PCOA chart and how I've arbitrarily categorized them. So I changed the colors. So I said, okay, great, now they group. So all these blue ones here, and I said, okay, what's similar among these? And so I went back and I looked at the patients and I said, well, not a lot actually. 2 of them had positive urine cultures, 1 had no growth. None of them are febrile, so maybe we were looking at a cytokine response. They all had abdominal pain and emesis, so it wasn't terribly helpful. Then I said, okay, well, maybe these guys will be helpful. But similarly, no. 2 had positive urine cultures, 1 had mixed growth, 1 had no growth. Some of them are febrile. And then these guys were similarly disparate. 2 had positive urine cultures, 1 had mixed growth, 1 maybe had a fever, a lot of nonspecific symptoms. So what I took away from this was that we as clinicians are really bad at telling when a patient with NLUTD has UTI. So I said, okay, well, this is a good exercise and learn how to process RNA. I didn't really get very helpful data out of it. So again, we're going to keep coming back to this question. So I thought, okay, clinically, how do we think about this? What are the categories that we need to examine? And so we come back to that AAP definition. So you were looking for a symptomatic child who has a degree of inflammation on the urinalysis indicated by leukocyte esterase or pyuria in the presence of a positive urine culture. But the problem is these things are always present within this population. So this data is taken out of cohort of children who are coming in for routine urodynamics. So definitionally, these kids likely don't have a UTI because you don't want to do urodynamics in a kid who's actively infected. You're going to make it worse. So in this patient population, about a third of them had more than 10 urinary white blood cells and 12% had more than 50. 45% of them had greater than 100,000 CFU on their urine culture, and 56% had urinary symptoms. And although I will acknowledge that they probably had urinary symptoms, which is why they're coming in for urodynamics, it goes to show that these 3 categories are really common within this population. So, okay, so then what do we do? So we want to look at the urinalysis. How good or bad is the urinalysis? And in case anyone was inclined to live tweet this data is embargoed until the 7th, so please don't. So we performed a retrospective cohort study at 2 different sites, here at UPMC Children's and at Lurie Children's Hospital in Chicago. And we looked at the data of all children with myomeningeal who presented for evaluation between January 1st, 2016 and December 31st, 2021, who were less than 18 years of age and had a urine culture and a UA collected. We defined UTI as per the umpire criteria. Umpire is a protocolized approach funded by the CDC. It's a kind of prospective cohort study in which they are using protocolized management from infants through the first couple of years of life to manage their bladder and their kidney health. And so they have a UTI definition that was developed by consensus of the umpire investigators. And that's what we used here as our definition. So in a patient that has at least 50,000 CFU is what we use, umpire says 100, with 2 or more of the following symptoms: fever, either documented or reported, hematuria, abdominal, suprapubic, or flank pain, new or worsened incontinence, new or worsened urgency, frequency or hesitation, pain with catheterization or urination in children who void, and malodorous and or cloudy urine. So together we looked at almost 1,500 cultures. We excluded people for those following reasons, including recent surgery, on treatment antibiotics, too old, not enough data in the chart to make a differentiation, those with immunodeficiency, which are usually our transplant population, kids without myelomeningocele who are inaccurately included, and we had just under 1,000 cultures. And this is what this looked like. So in our patient population, we had just about 12% that had a UTI. So assuming a prevalence of UTI within this patient population of 12, each child here represents a child of myelomeningocele. This blue dot here are the patients with false negatives if you rely on pyuria, which we define as greater than 10. These 11 in pink are the true positives. These 30-something are the true negatives, but over 50% of our patient population will have false positives if you rely on pyuria as defined by 10 white blood cells to diagnose UTI. So if you break that into patients that are inaccurately diagnosed in the blue and accurately diagnosed in the green, you can see that we have 2 false negatives, 47 false positives, 10 true, oh, sorry, let's change to leukocyte esterase. It's actually quite similar. Leukocyte esterase is an enzyme made by white blood cells, so they're often quite collinear. So again, the take home here is that if you rely on leukocyte esterase, you have about 47% of your patients will be false positive for UTI. And then we look at nitrites, it performs a little better. Again, blue, inaccurate diagnosis, green, accurate diagnosis, but you still have a fair number of false positives if you rely on any of these urine parameters. And this is all comers with spina bifida or myelomeningocele. So then we want to divide them into patients. So all comers and then those who use clean intermittent catheterization or CIC. And we compared it to the general pediatrics population. And this data here is taken from the 2011 AAP CPG, in which they report these data for the UA. So you can see nitrites, similar sensitivity, and the specificity is a little worse, but not much worse. But where you really see the difference is in pyuria and leukocyte esterase. It's actually a little more sensitive in kids with spina bifida, but that's because pretty much everybody has some pyuria, so that's why it's sensitive. But where it really falls apart is the specificity. So again, a lot of these kids have pyuria, so you cannot rely on it to diagnose a UTI. And it's even worse in children who rely on clean intermittent catheterization. And leukocyte esterase is similarly nonspecific. So this is a problem, and the problem really falls within the area of antibiotic resistance. If you are using imperfect methods to diagnose a UTI, you're going to give these kids too many antibiotics, and you're going to really cause problems. So this is some of my fellowship work. We wanted to document the burden of antibiotic resistance that is seen in children with myelomeningocele. So first we took all urine cultures that were done at a single center between 2008 and 2014. And these are all kids with NLUTD. And we looked at 3 different groups, any kind of bacteria that had the potential to be resistant to 3rd generation cephalosporin. So these are usually Enterobacteriaceae. And of note, we had to use a phenotype, not a genotype, because we weren't able to genotype all our organisms and they're not all ESBL producers. So we went based on the sensitivities. So the top is the 3rd generation cephalosporin resistance. The middle red here is VRE or vancomycin resistant enterococcus. And the bottom green is Enterobacteriaceae that's resistant to carbapenem. And as you can all see, they're all increasing over time. But we thought maybe this is just a trend that's reflected in our entire patient population. Maybe it's not limited to children with NLUTD. So then we took all urine cultures from that center between that time period, and we divided between those with NLUTD and those without NLUTD. And this bottom line is equally as complex a patient population and includes our oncology patients, solid organ transplants, stem cell transplants, other medical complexity, just not documented neurogenic bladder. And so not only is the rate of 3rd generation cephalosporin resistance higher in those neurogenic bladder, it's also increasing at a much faster rate, really underscoring the scope of the problem here. So coming back to the question, well, what do we do about this? How do we diagnose it? So I think about this in 2 sides. There's a host side and there's pathogen side, and then there's interaction. And we're going to talk a little bit about the host side to start. So I decided to look at antimicrobial peptides, or AMPs. These are proteins that are produced by the urothelium and serve in the innate immune response to specific bacteria. This is the first one I looked at solely because I had previous experience with it. It's called NGAL, or neutrophil gelatinase associated lipocalin. It's produced by the alpha intercalated cells in the kidney, specifically in response to LPS in the situation of the UTI. And the way this works is that it binds the enterocheilin iron complex. So this here is enterocheilin. This little red dot in the middle is iron. And enterocheilin is produced by gram-negative bacteria. They require iron to survive, but can't make it themselves, so they have to obtain it from the environment. So gram-negative bacteria, they make enterocheilin, it kind of goes out, it scavenges iron, it brings it back. NGAL then competes with the bacteria for the endothelial iron complex and exerts a bacteriostatic effect through that mechanism. And so this is some early work that I'd done with my prior group at Columbia, and we were able to find out that NGAL is highly expressed by the kidney in the situation of the UTI. So this is the Black 6 mouse. We had tagged the NGAL locus with the luciferase gene, so we're able to and then we were able to like in vivo image the areas of NGAL upregulation. So using a UTI model within the C57 Black 6, we induced a UTI and are able to localize the NGAL upregulation to the kidney within 12, definitely 24 hours. And then this is some PCR data looking at NGAL expression in the kidneys pre and post UTI in the bladder. And we can see that there's significant upregulation in the kidney after UTI. So we do know that NGAL is upregulated after UTI. And we see this clinically. These are two different papers that we looked at NGAL within different patient populations. This is adults with spinal cord injury. And we do again see elevation of NGAL compared to people without UTI. And this is an AUC curve from kids with myelomeningocele showing a superior AUC compared to what we used as clinician opinion and nitrites as our comparator here. And then from that same study in which we looked at children's spina bifida, we were able to find that NGAL has a really high negative predictive value. So using a standardized or non-standardized form, which I will not bore you as to why we do that, you can say that NGAL is really good at telling us when a kid doesn't have a urinary tract infection. So the really exciting thing to me is that NGAL has recently been approved for the diagnosis of AKI, urinary NGAL, AKI, and I believe we're actually getting it to the platform this summer, so the reps tell me. So maybe some interesting clinical work in the future, being able to look at the real-time performance of NGAL in UTIs and kids with NLUTD. Okay, so then we said, okay, let's move to the pathogen side. We've talked a little bit about the host response. What about this bacteria? And if you take home nothing else from this talk, if you are thinking about what you're going to do for dinner, what your patients are going to do, did you sign that discharge summary? I want you to look up and think that urine is not sterile. Please, again, nothing else. The urine is not sterile. You can go back to what you were doing. So we are going to talk a little bit about the urine microbial ecosystem, or the urobiome, which is what I spent a lot of my time doing. Now, the reason that the paradigm around urine sterility has been so strong for so long is because the methods at which we use to detect bacteria in the urine are imperfect. So think about it a little bit of the streetlight effect. The standard urine culture, what we use to culture urine, is specifically designed to look for E. coli and other gram-negative uropathogens. So we refer to this, this guy here, he's saying, the police says, is this where you lost your keys? He said, no, I lost them in the park, but the light is better here, suggesting that we are looking solely using a technique that looks for one bacteria, but there are bacteria everywhere. We're just not highlighting it. And so this is what we do for a standard urine culture. You take 1 microliter of urine, you plate it on mostly plated on 2 different plates, you incubate it at one condition for 24 hours, and we see if anything grows. The problem is, it doesn't grow a lot of things. So a group out of Loyola Hospital in Chicago, they developed this protocol called the Expanded Quantitative Urine Culture, EQUC, and there are a variety of different protocols at this point, but this is the original one, in which they use 1, 10, and 100 microliters of urine. They plate the urine on many different plates. They incubate them under many different conditions and for different periods of time. And doing this, as you can tell, urine is actually not sterile. So on the left here is a standard urine culture. This is the same specimen. Nothing grows. Using the EQUC technique on the right, we see pretty significant growth. So the problem is, if you were calling something sterile, you're not using the appropriate methods to find it. If we use better techniques or techniques designed to look for different bacteria, you're going to find a more robust microbiome. And using this EQUC, this culturing technique, we've been able to validate a lot of the sequencing results in microbiome. A lot of microbiome data is come from sequencing. We sequence the 16S portion of the rRNA gene. And because you're relying on DNA to sequence, that doesn't tell you whether or not that bacteria was live or dead, whether it was there currently, whether it was there previously. It just tells you that at some point that bacteria was in that space. The fact that we're able to validate a lot of our sequencing results using culturing techniques gives us a lot more validity to our results of the urobiome science. And also part of the reason that urobiome science has really lagged behind other areas of the urobiome is because the paradigm of urine sterility is so strong that in the first iteration of the Human Microbiome Project, they didn't even include urine. They just kind of assumed it was negative and then moved on with their lives. So we're going to take a bit of a tangent here to talk just very briefly, how do you interpret microbiome data? The field of bioinformatics, it is complex. I have to work with a lot of people, including Dr. Raja Sundaram within the bioinformatics core here in Rangos, because it is an entirely separate field from Bayesian statistics, and one that I do not have the bandwidth, frankly, to be able to figure out. So I want to give you a quick and dirty how we're going to talk a little bit about microbiome data. So we talk about diversity a lot in microbiome data, and there's alpha, beta, gamma that we generally think about. Alpha diversity is just simply the number of different bacteria within ecological space. So sample 1 here, you have 5 different colors. You have 5 species, that's a high alpha. Compared to sample 2, you have 2 different colors, 2 species, low alpha. So high alpha, a lot of colors, low alpha, low number of colors. I'm going to be showing you data in these relative abundance charts. So this is the best one I could find. It's from honeybees, if you care. Each column here represents a different sample. And so you can see these colors here, 1 bar, 1 sample, low number of colors, low alpha diversity. Bars over here, more colors, higher alpha diversity. So few colors low, high colors high. We don't mean to talk about honeybees. It just happens to be the best example I could find on a quick search. So we're going to shift back to the urine. And so this is how we use this clinically. This is some data that Dr. Sheikh's lab put out in which they looked at a lot of urine cultures from children under 3, and they divide them into those that likely had a UTI, those that maybe had a UTI, and those that likely did not have a UTI. And as you can see here in the group that likely had a UTI, low number of colors, low alpha diversity, compared to those with unlikely to have a UTI, a lot of colors, high alpha diversity. So in this paper here, and this is really the some of the early work for Nader's more recent paper in which they make the argument that we should be lowering the colony forming unit cutoff to 10,000 CFU from 50,000 CFU, is based on the concept of alpha diversity. So how does this apply to kids with neurogenic bladder? So when I started this area, there was no data on neurogenic bladder in children. So first thing we had to do was describe it. So since I've moved here, I've been collecting samples from the spina bifida clinic using a cross-sectional approach. And so I sequenced part of them just to get more of a quality assurance method. And so what we see here are the most common bacteria within the urobiome of children with spina bifida. So the most common being E. coli, followed by staph and unspecified Enterobacteriaceae. Now these 1, 2, and 3 here are the most common bacteria that are seen in the urobiome of otherwise healthy children. So your number 1 is Prevotella, followed by Paptinophilus, and then E. coli. So already we can see that there are differences in the urobiome of kids with spina bifida, and this is specifically spina bifida, compared to those without. And within this cohort, I was able to have a couple kids with UTI. So I thought, okay, great, let's look at diversity. So this is kind of the average diversity of children without UTI and those with UTI. And I said, oh, this is fantastic. Lots of diversity here, lots of colors, high alpha diversity, low number of colors here relative to this one, low diversity, fantastic. And we looked at this statistically and we saw that there's a difference. Is that, okay, oh, that's great. We're finding patterns and we're able to look at heat maps here and find some associations. And we can say, great, we see E. coli, that means this kid has a UTI, we are onto something. And then I looked at all the samples independently. So these are those 71 patients. And you can see there's a lot more patients here with just 1 color in their urobiome. And of note, red is E. coli. So all these patients with a red bar here have a urobiome that's dominated by E. coli. And I said, oh, well, shoot. So on an individual patient level, this isn't really very helpful. So where do we go from here? I can tell you that the urobiome of patients is very different. I have looked at this in about 1 million different ways. Do they catheterize? How do they catheterize? How long do they catheterize? Do they use antibiotics? Do they not? Do they flush? I've looked at this and I can't elicit any patterns. So I have then had a problem. So let's think, thinking globally about this area of research, we have issues related to the gold standard. There's always going to be criticism within this area of research of how you're defining UTI because there is no gold standard. It's an appropriate criticism, but it's going to be a problem. There are a lot of confounders in this patient population. We care for these children. We know how medically complex they are. It's difficult to control for anything that might potentially affect the urobiome. And then logistically, it's challenging. I suspect what we're going to need to do is a longitudinal design to understand how the urobiome changes in the setting of various stressors. And logistically, that's really challenging. I can't, serially collect urine from every child with spina bifida and hope that someone will get a UTI. So I decided to move to mice, which is a fun challenge for being a clinically trained researcher. So moving to the mouse urobiome area, first we had to say, well, what's the mouse urobiome look like? And shockingly to me, probably not to you, no one actually has set about figuring out what it is. So first we had to figure out what the mouse urobiome looks like, and it looks like this. In case you were curious, it is dominated mostly by staph. We have some Enterococcus. What else is here? Mammiliococcus, which is like a mouse form of staph, in case you're curious. But so we do know there's a mouse urobiome, and these are samples that were done at my prior institution. So we said, okay, well, this is the mouse urobiome of mice from Washington, D.C. What do they look like in Pittsburgh? So this is the same data, different way. This is a heat map here. And so these are those samples that I showed you from Washington, D.C. We repeated the experiment here in Pittsburgh. And what we found is that the most prevalent and abundant genuses are the same between these groups. So that gives us a little validity to our results saying, okay, we don't have a huge effect of the environment or the location or the water source or the chow, that we're seeing a lot of similarities between these groups. And then we cultured the urine too. And again, a lot of the bacteria that we're able to see on sequencing, we're also able to culture. So not only are those results, we're able to replicate them, we're able to give a little more validity by use of culturing techniques. So we feel fairly confident that what we are seeing is actually there. But the way, I don't know if you're logistically thinking about how you would collect urine from a mouse, it's been a problem. So what we normally do is that we take the mouse, you take a betadine or alcohol swab, you kind of wipe the perineum, and then you scruff them over something sterile, and you press on the bladder, and you hope that they pee. So you're always going to have some contamination from the area. You can't avoid it. So we collaborated with the Animal Imaging Corps, with Eugen here in Rangos, and we did some suprapubic aspirates of mice using ultrasound guidance. And so we obtained paired suprapubic aspirate and express samples. So same mouse, express samples are here on the right, the aspirated samples are here on the left. And so we do, even after aspirating the samples, and probably the most sterile technique we could do, we still find a urobiome in all mice that we sampled. The only notable difference is we have a decrease in staph, which we assume is from the skin, Burkholderia and Ralstonia, both which are environmental bacteria. So again, what we take away from this is that we see a urobiome in all the mice, and we think that this is actually more indicative of the actual urobiome because we have such influence of staph, which is here in the pink. And I think this kind of mustard color is Burkholderia, and the red is Ralstonia. So we think that this is the more accurate urobiome. I bet you are all really curious as to what bacteria are found in the urine of mice when you woke up this morning, and now you know. But that brings us back to the question, what does the urobiome look like in mice with NLUTD? These are all wild type mice. These are mice that are doing their own thing. So, and the way that we model neurogenic bladder in mice is we use a spinal cord injured model. There are no post vivo viable mouse models of spina bifida. I spent a very long time trying to figure out one. And so we have to use a spinal cord transection model, which is a surgical procedure. So on this graph here, this is a longitudinal representation of the Shannon Diversity Index, which is the numerical way that we look at the alpha diversity over from day 1 post-injury to day 31 post-injury. And we sample these animals every other day. And so because this is a surgical procedure in which we open the dura, we have to give these animals antibiotics. So that's what's done here through day 7. And as you can see, that there's the urobiome, the alpha diversity is pretty stable up until about day 16, where there's this inflection point. And then the diversity stays pretty low after that. We wanted to understand what was driving this point. And so then this is the same data, but in relative abundance charts. And again, you have the antibiotics shown here through day 7. And what we think is driving the urobiome here is this increase in this dark blue color. And this is Enterococcus, which actually makes a lot of sense. We are pretty excited about this because the antibiotic that we give is ampicillin. For those of you that don't do a lot of clinical work, ampicillin kills gram-positives, including Enterococcus. But what was interesting to us is that we see a little bit of Enterococcus here, and then we don't see Enterococcus, but then it starts to dominate here on day 11, 13, 15, and then day 17 it takes over. And then we have a resurgence of staph in the green here at day 25. And what we think this indicates is something called colonization resistance. And it's really, I think, hopefully reflective of what we actually see clinically in this population. So if you think about a urobiome, it's like an ecological community. It's relatively stable within the absence of large stimuli to perturb it. So you have different bacteria, they use different niches there, they use different resources, and it's relatively stable. So that's why when we're inducing a UTI in mice, we have to put in a whole lot of bacteria. We have to put in like 10 to the 7th E. coli to create a UTI because we can't get it to stick because the urobiome is so stable. Now, if you give antibiotics, you're killing off your gram-positives, all of a sudden you have this opening in resources and like the ecological community there, and that gives the opportunity for Enterococcus, in this case, to dominate the urobiome, and then it takes over, and then it's pretty stable afterwards. And the other exciting thing to me anyway, is that this is reflective of what we see in people. So this is some early work that was done by my mentor in Washington, D.C. at the National Rehab Hospital. So this is another way of looking at the same data. These are the organisms that differentially present between adults with spinal cord injury and those without. If the long bar is gray, that means that bacteria is more common in people without spinal cord injury. If this long bar is white, it's more common in people with spinal cord injury. And as you can see, Enterococcus is one of the bacteria that's more common in people with spinal cord injury compared to those without. And this was exciting to us because not only that show that our mouse model is actively reflective of what we are seeing in our clinical population, therefore we can hopefully use this model going forward to further investigate UTIs in this population. But we had some residual questions. Why do the differences persist? So we seem to understand why enterococcus takes over, but at least in that longitudinal data, it persisted. And we have some samples out to about 6 months right now, which I'd hoped that we had had, but we do not at this point. So we presume they persist because we see that in the people. We'll confirm that in the mice. And then the question is there an association between differences in the urobiome and the risk of UTI in people with NLUTD? So we're going to go a little bit back to histology now. If you remember, this is what the urothelium looks like in a person with a normal bladder. You have your suburothelium here, you have your basal cells in the green, your intermediate cells here in this pink, and then you have the superficial or umbrella cells in the purple. And the way that we look at this histologically is the purple cells are staining positive for KRT20 or keratin 20. And then on top of that, we have a variety of mucins, what I call the urothelial-associated glycans, things like uroplakin and the gag layer, and then you have, and then you have uroplakins here. And as I mentioned, the gag layer, this is, the gag layer is, they're proteoglycans. So these are oligosaccharides that are linked to a core protein here, and they exist on top of the urothelium. And the hypothesis is that it kind of serves as part of the barrier function of the bladder. And what happens after spinal cord injury is that we see perturbations to the urothelium. So this is the image using the same kind of color combination of what happens to the bladder after spinal cord injury. And we see loss of the superficial umbrella cells. So these kind of purple ones get lost. And we see that it's repaired by cells from different layers. So you have cells from both the basal layer and the intermediate cell layer who repair the urothelium. So what we see is in the setting of spinal cord injury, we see disruption to the urothelium and we see an aberrant repair. And this is what this looks like histologically. So this is immunofluorescence here. This is a control mouse. So this is the urothelium here. These blue dots, that's DAPI, that's a nuclear stain. And this light green here is KRT20, looks showing the umbrella cells. This is what happens when you do a spinal cord injury. Same markers, so the DAPI is in blue, the KRT20 is that umbrella cells in the green, and we see patchy loss of the KRT20 cells following spinal cord injury. Now, what we're really interested in is understanding, do we see this loss of the gag layer? And the reason we're really interested in that is that there's some really interesting early work in the gag layer showing that it's really involved in protection against UTIs. And the thought being that the urobiome can kind of exist within the gag layer. You know, we see that we find the bacteria in the urine, but it doesn't make sense that every single time you pee, you're going to lose the urobiome, and then the urobiome is going to crawl up your urethra from your perineum and kind of reconstitute itself in the bladder between voids. That's just probably not going to happen. So it has to live somewhere in the bladder, but where? And we know histologically, we don't see this in the urothelium. It's not invading the cell tissue layers there. So where does it live? And I propose that it lives within the gag layer. And there's some precedents for this within the gut. We know that the gut microbiome is strongly associated with different areas of mucus layer within the epithelium of the gut. It's not urothelium, epithelium. And then we know that in some early studies, if you ablate the gag layer, mice are more likely to have UTIs as indicated by positive cultures of homogenized bladder tissue compared to those without. So I propose that these bacteria live in the gag layer, and the gag layer is probably altered after spinal cord injury because we see this loss of KRT positive 20 cells. So first we wanted to look at, okay, we know that we see this perturbation of the urothelium following spinal cord injury. What happens to the gag layer? So in this image here, this top line are your control mice. These are uninjured C56 black 6. This is day 1 following spinal cord injury, and this is day 3 following spinal cord injury. This first panel here is a KRT20 that indicates the umbrella cells, which again, we see loss of in day 1 and day 3. Then we use wheat germ agglutinin to look for the gag layer. And I acknowledge that this is a really non-specific marker. Wheat germ agglutinin binds glucose, essentially. So as you can see, there's some here in the urothelial space. But we look at this histologically because it looks at kind of all those urothelial-associated glycans, but it's not specific for any one in particular. So in the control mice, we have a pretty robust layer here. And then we see a little bit of loss at day 1, and then a significant loss at day 3 with just a little bit of that positive staining here. And then if you we do think they co-localize. One of the questions we have is whether these specific glycans are produced specifically by the KRT20 positive cells. We don't know. What we do know here is that on day 3, we see the loss of the KRT20 that corresponds to the loss of wheat germ agglutinin. And again, this is why we are curious. I talked a little bit about this, But this is a schematic of the urothelium, and this is how UTIs happen. So UTIs are uropathogenic E. coli, UPEC. They bind to the urothelium in a type 1 pili dependent manner. So they bind to these pili. They then get either expelled from the urothelium, or they go through a pathway where they survive intracellularly. So these UPEC can then survive in the superficial urothelial layer. They then form these interbacterial cellular communities, or IBCs, where they kind of exist within this quiescent state until they take over the urothelial cell. The cell gets exfoliated, it lyses, and then it releases more bacteria within the urine, thus propagating the cycle of UTIs. Occasionally, some of these IBCs, once the cell exfoliates, can efflux, turn into a filamentous form. So they go from kind of like more of a quiescent form to a filamentous form. They go down to the lower layers of the urothelium, and they form these QIRs, or quiescent intercellular reservoirs. And QIRs, both IBCs, but QIRs definitively have been implicated in recurrent UTIs. So again, our hypothesis being that if you have a gag layer on top of here, and your gag layer not only is preventing the uropathogens from accessing the urothelium, but it's also home to a lot of beneficial bacteria, you prevent the ability of these uropathogenic bacteria to A, bind, B, develop IBCs, or intracellular bacteria communities, and C, QIRs. And if you can prevent that process, can you prevent the cycle of recurrent UTIs in children with spina bifida? So that's our overall hypothesis. We are currently investigating that. And so with that, I went through faster than I thought, but in conclusion, remember, I want you to remember this: urine is not sterile. If you find something, you do not need to call ID. You do not need to say this kid has a UTI because I found it. It's probably just hanging out there. We also know the pyuria, bacteriuria, urinary symptoms, they're common in people with neurogenic bladder. We talked about the fact that the routine urinalysis, it's not good for telling if a kid has a UTI or not. Still not sterile, still not sterile. We think that there's the increased risk of UTI in people with NLUTD is mediated by injury to the urothelium, specifically the gag layer. And just guessing it, it's still not sterile, guys. So I don't know what a UTI is in this population. We're continuing down this path. I hope to have some more answers for you in a couple of years, but it's been a fun trip. And with that, I'd like to thank my lab members who do most of the work, my mentors who've been instrumental in helping me get here, the collaborators that do a lot of work and help guide me along the way, members of Spina Bifida Clinic who collect a whole lot of urine from me, and my funding sources. And I'm happy to take any questions.